Hello there, I am Dr. Swami Iyer, and this is the first of the best of SOHO presentations. Very fortunate to have two distinguished speakers with me today. They're going to speak on acute lymphoblastic leukemia. I have with me Dr. Dieter Hoelzer, who also is the incoming president of the Society of Hematologic Oncology. He comes from Germany, from Frankfurt. And towards his left is Dr. DeAngelo from the Dana-Farber Cancer Institute. Welcome.
Thank you.
Thank you.
So we had a very good ALL session this morning, don't you think so?
Oh yeah.
It was wonderful.
And were there anything that caught your attention immediately off the discussions that we had?
I think there were some new studies, some new sorts, and we now in a stage where we have to merge the conventional chemotherapy with excellent results and the targeted therapies coming up.
To add on that, I think the differences between the European approach in terms of measuring minimal residual disease is extremely important. I think it's not enough, at least in ALL, to get into remission, but you need a deep molecular remission or a deep remission, however you're going to measure it. In the United States, some centers are measuring it using PCR-based, many are measuring it using flow-based, but more often than not, patients are being treated and there's been no measurement of MRD. And I think given the data from the German group, it's really essential to use MRD data to make treatment decisions in adult patients with ALL.
No, absolutely. I think MRD is a very good point. And before we get to the MRD in a second, could I ask you, Dan, you started off with the presentation on how I treat ALL. I guess there is this difference between European and Americans, and even here there are at least two different schools. And you had a very elegant presentation on the pediatric-inspired protocols. Could you throw some light on that?
I actually don't think we're that far apart. I think we're more close than we think. I mean, the drugs are the same. In the US, as well as in Europe, there was a divergence between the pediatricians and the adult oncologists in terms of how they developed clinical trials. In the United States, it was mostly through cooperative group and the CLGB, the ECOG, the SWOG, and MD Anderson, large enough to do their own, all developed different protocols. Some with asparaginase, some without asparaginase, some more intense than others. And I think over the course of time, we got away from the principle of using less myelosuppressive agents and more steroids, vinca alkaloids, and maybe asparaginase. And we just have been incorporating that back into our therapy. Doesn't mean that that's the only way to get a good result, but clearly in comparison to some of the cooperative group regimens in the United States, it seems to be superior. But I think we're closer than people think. We're just calling it a different name.
Yeah, no, absolutely right. Dr. Kantarjian made a point saying that the comparison between the augmented BFM and the hyper-CVAD data looked very similar. And having said that, the takeaway point from your presentation was that if you have to use pegasparaginase in a community-based setting, be cautious. Do you want to?
Well, I think you need to know what you're doing. I think begrudgingly in the United States, ALL is still a rare disease, and it's still primarily treated in the community. And I think that when you're treating one patient or two patients a year, with all the complexities and complications of the therapy, you need to have some comfort level in terms of treatment. We always encourage patients to receive therapy in a larger academic practice or even a large private practice, but a larger practice where there's some comfort level. And for the treating physician to use a dose-intensified pediatric type regimen for the first time without knowing the nuts and bolts is not trivial. So that was really the point I was trying to make.
Dr. Hoelzer, how about your
experience? I think the situation is somewhat different in both topics we just discussed. So I introduced in Germany MRD together with Monika Brüggemann for every patient. So right from the beginning, the investigation for minimal residual disease is centralized in one lab. That's important. And second, very early, we convinced the insurance companies to pay for this investigation because they could learn that they save a transplant or that we have to use a different drug. So we have now 1,500 patients in a row, all investigated at specific time points, and it's quite clear minimal residual disease is the most important point for the treatment strategy. And the second point is pegylated asparaginase. I think it was a mistake from the adult doctors treating ALL that they moved a little bit towards the direction of AML. It's quite clear. You see 10 AML patients and 1 ALL. So we introduced some elements, for instance, in Germany, called a HAM regimen, a very intensive consolidation, and it didn't bring any profit, and even increased the complication after the transplant. Now in the last 10 years, we are moving back to the more ALL-specific elements. Actually, in Europe, most of the trials are anyway derived from pediatric trials, BFM. So there is not so much need to move to so-called pediatric-derived protocols, but we have great experience with pegylated asparaginase. We are not afraid anymore. We have 1,500 patients, same cohort, and after a while, you can deal with the complications. You have some precautions, it was mentioned today. If you have a BMI, which is too high, if you have alcoholics, now we learned that we have to control by an ultrasound the liver. And if there are any signs, we stop and reduce it. And the fatal complication rate is extremely low. You just have to handle the hepatotoxicity. And I think the doctors learn it, and we too.
Excellent points, Dr. Hoelzer. So coming back to the point of MRD, I just want to stress on that, and you said it's very important. Obviously, you set the standard, and there is even this idea of having a Europe-wide, Euroclone study group to look at the MRD. One of the problems we have is there's so many different companies offering MRD now, and some of them are covered by insurance, the question that you brought up, and talking about harmonization, the major theme here. How do we go about doing this? The cooperative groups, MD Anderson, any thoughts and suggestions on the MRD part? And we've learned a lot from the pediatric group, but the big question is, and somebody asked the question, are we ready for MRD today to make a decision to send a patient to transplant or not, if everything else being equal?
I mean, in Europe, we are now relying on PCR, because it has a greater sensitivity. If we look to the published data, also flow, if it's a good flow, 6 to 8 colors, it's quite good. I'm saying this because there are many countries, I'm not talking about the States and Europe, where they would like to do MRD. And instead of saying you just have to have a very qualified lab, if they can do immunophenotyping on a good level, they can also follow the MRD. Actually, it's my experience getting questions from patients somewhere. They have an excellent phenotyping and diagnosis, but they don't follow. So they could, from the qualification, they could easily do follow-up by MRD.
Yeah. But it does take a good flow cytometrist to differentiate between, especially in those patients with ALL without an aberrant marker. For those patients that have an aberrant marker that is an additional marker that you can follow, it's very easy to use flow, very easy, and it's quite sensitive. But if there's no aberrant marker, which is present about 20, or absent, I should say, in about 25% of cases, it becomes a little bit more difficult. And there you need a really good pathologist to follow it. So not every lab can do it. And that goes against to again to Dr. Hoelzer's point of centralization being very important. We don't have centralized labs in the United States. We have a lot of labs doing trying to do a lot of very good work, but the experience in each individual lab or center or reference lab is very different. We're clearly not there in the United States. I would say it's a minority of the centers that are doing MRD by whatever measurement that they're doing. Some of it because the inability to get third-party payers, and some of it because they're just not equipped. But which is obviously from Dr. Brueggemann and Dr. Hoelzer's data a sad state.
Obviously, it goes back to the point you made, is do it in a center that knows how to treat and where the standards set for MRD. Otherwise, try and have guidelines that you can follow. So going to the topic of more exciting topic of monoclonal antibodies that you presented, Dr. Hoelzer, and CARs. It's the hottest topic, and you see, I think, more pieces of literature is coming out of Wall Street Journal than the New England Journal of Medicine. So what are your thoughts, and how are you?
Do you know, if I may, a personal statement?
Sure.
I'm working for 35 years in ALL, so I founded the German multicenter group, which has now 140 hospitals, in '81. And there were decades highly frustrating, just playing around with a little bit of increasing chemotherapy, but even no new drugs. And I think the targeted therapies, first with the tyrosine kinase inhibitors and now with the monoclonal antibodies, it's changing the situation very much. More in adults, because the pediatricians cured already 80 to 90% just by chemo. But our situation was frustrating. And now we have a lot of new possibilities, very attractive and very effective. The next step is, what is the best place to incorporate these treatment with monoclonal antibodies, including the cellular therapy with CAR T cells?
And blinatumomab was approved with all that effort that coming out of Germany, and we have other exciting drugs, inotuzumab, ozogomycin. Of course, you have the other agents, Rituxan, and the other anti-CD20s. So of course, the questions for both of you, blinatumomab, now that it's approved, its role is going to be upfront, and where do you see that going? And number two is with the newer agents, with inotuzumab, the excitement there is in the elderly ALL patients. I guess you made a statement that Rituxan perhaps didn't add much to the elderly ALL patients. And
I think unless the time when we have all the new monoclonals in frontline, it's difficult to decide what it's better or not. So it might be in the future, we have to find the best place for each of the monoclonal antibodies. We could even think of combinations or sequential therapy. If you have a shedding of an antigen, you may go to the next one. It's too early, but very soon we will have the opportunity. And an additional point is, not mentioned today, if you give inotuzumab or blinatumomab, we are just looking up to now for the MRD, for the CR, and an overall good response rate. But we are not aware which subclones we are eliminating. And it might well be that if we look careful into the data in frontline, that we eliminate different subclones with different monoclonals. I mean, one could imagine. Sure. And then we would tailor our treatment differently.
Yeah, I mean, I think this is most leukemias are subclonal or clonal, and so you get different populations, and these agents which are targeted are going to select for, what they're not targeting, and so it's going to be interesting to see that. I mean, but the excitement, as Dr. Hoelzer mentioned, is really moving these agents up front. I mean, for the first time, we're seeing response rates in the relapse setting that are extraordinary, and not only are they high remission rates, but also associated with extraordinarily high MRD negative status. And for the first time, we're seeing a large percentage of patients being able to move on to subsequent transplant. So now you move those agents up front. Not only I am hopeful that we're going to be able to improve the outcomes, but also maybe in the future start minimizing some of the cytotoxic drugs. I mean, it's a guess, but I take the thought on the presentations, on the studies that were presented, the inotuzumab plus mini hyper-CVAD, where the anthracycline and some of the doses were reduced, yet the results were outstanding. And then the new SWOG study that Dr. Anjali Advani had presented in older patients with a really non-chemotherapy approach to patients. And it's very early, but it's for the first time, it's really exciting.
And having said that, the excitement continues with how this can be combined with the TKIs, and we come sort of into the era of the more well-studied biology, which is the pH-positive ALL, and now we have the pH-like ALL. And
but to add to this point, we had just a discussion before. We go to a non-genotoxic, avoiding mutations, chemotherapy, but we have also to figure out which patients need really a transplant. That they need a transplant in a relapse refractory situation, no doubt about it. And there are still enough patients. However, treatment-related mortality is still 20%. So if we can spare a few transplants in a well-defined situation after the monoclonals, it would be great. The data are not mature enough. And again, I think we need frontline data to come to a good decision.
No, absolutely. So relapse refractory is transplant ideal, and incorporation of monoclonals upfront might then ask the question whether it can obviate the need for a transplant. But on that same note, your presentation from your group and from Canadian group was the pediatric type regimen and the possibility of not needing a transplant. Of course, it's a non-randomized study presentation, but it does bring up a lot of questions that Dr. Hoelzer talked about, the treatment-related mortality. So what is your take on that?
Well, I mean, I think we have a very good randomized study, the ECOG 2993 study, that compared a chemotherapy regimen to transplant in an attempt to treat, not an attempt to treat, but in a genetically randomized fashion. That is, if you had a donor, you went to an allogeneic transplant. If you didn't, you either got chemo or an autologous transplant. There's a lot of questions with that study, and the 13-year study that it took to accrue, the realization that although overall patients benefited from transplant, it was really limited to the younger standard risk patients and not the higher risk patients, which is in deference to most of the other studies. And the other thing was the comparator arm. The chemotherapy was a non-standard comparator. So now, as the improvements are in the treatment of young adult patients with, however you want to say it, a dose-intensified regimen, a pediatric-inspired, whatever label you want to put it on, as those strategies are improving and resulting in better survival rates, it begs the question, do you need a transplant? And at least the data from our group would suggest no for the vast majority of patients. There are still subsets of patients where there's a question, and MRD positive, I think we're not really clear about the pH-like. Maybe MRD, in that situation, maybe MRD still rules the roast. There are certain cytogenetic subgroups, like the Philadelphia, where I think a transplant is still unclear, but more testing and more experimentation.
Could I just ask you for a moment, if you
Sure.
had a pH positive patient in CR1 and doesn't have a donor, it's easy, the patient has a donor but doesn't have a donor, and all you can find is a haplo or a cord, would you transplant this patient?
I wouldn't do a haplo or a cord, but in our center we would transplant patients with the Philadelphia chromosome who had either a related or unrelated donor.
I mean, if you include the unrelated donors, and if you search early enough, in our study we have now 900 patients being transplanted in first CR, and 60 to 70% are unrelated donors. The outcome is equal between sibling and MUD donors because you have a better donor selection in a MUD. So it's still a candidate for a transplant. But several study groups look whether they can segregate patients which may not be a transplant. But there is not a real study, in contrast to the pediatricians, showing that we can omit the transplant. Even in the Italian study, finally, after relapse and so on, MRD positivity, 50% of the patients receive a transplant. So it's not settled.
It's not settled. So that's a fine, ripe question to ask in the context of a clinical study.
Yeah, but if we combine the TKIs, less intensive chemo, and a monoclonal, it may look different.
Oh, absolutely. I think that the key, that's a very key. So I still think MRD is important in that setting, and if we're able to get with the combination of a TKI and a monoclonal to really drive that down, we may be able to forego a transplant, even in that setting. It's just unclear.
Excellent. So just to change gears with the TALL, there was very, very fascinating data that is presented about the different mutations, not just the notch mutations, but the JAK-STAT pathway, and in a lot of work done in mice and in vitro data. What are your thoughts about?
The reality is, the current, we have 20 to 25% TLLs. They do better, particularly with pegylated asparaginase, but we have no antibody therapy at all. We had Campat CD52 directed, but otherwise we just rely on nelarabine, which is a T-cell specific drug, also associated with toxicity, not to neglect, but all the other things like notch inhibitors are ongoing, but not proven in huge trials. So in our hands, the B-lineage ALL is improving more and more as a total, and TLL, particularly the subtypes, mature and early TLL, there's a substantial need for improvement.
Yeah, no, I agree. It's we need to start moving some of these agents up front, but it's just hard. It's a rarer disease, and as Dr. Hoelzer mentioned, the TALLs do relatively well. So it's a challenge to in a yet rarer subset to really do a lot of early clinical trial development.
But given that if there's the theoretical possibility of everybody coming together, just a study with ruxolitinib in that setting, given that a third of the patients with TALL have JAK-STAT mutations.
Yeah, also the notch inhibitors, we had some pitfalls because it was too toxic, but there are new trials ongoing. But it's still not standard. In TLL, there's really a need for improvement.
Yeah. But it does open up the door. So you have 100 patients, about 2/3 will have a notch mutation, and about 1/3 will have an IL-7 JAK-STAT pathway mutation, somewhere along that. So it raises the possibility that in the future we may be treating these patients in a different way. But for right now, it's a longer hurdle, or a higher hurdle.
I think it's a great start having discussions such as these. Yeah.
But there's also publications showing that relapsed TLL patients express 38% or so CD30, but there are no studies using it to go at least with prentuximab in the relapse refractory situation. So there's, I think, as Dr. DeAngelo said, there are different subgroups. It's not so easy like inotuzumab or blinatumomab. We have to go for the subsets in TLL.
So I sort of want to end with this thought and then next generation sequencing. We talked about immunophenotype and MRD, and that's where I think our unraveling the biology comes up, and we have all these next generation sequencing, targeted sequencing, which unravels more mutations, and eventually it becomes a clonal evolution, and it's the battle of the clones. Where do you see that fit into the ALL currently with the treatment paradigm and also in the context of clinical studies?
Well, the next generation sequencing platforms that most of us have are not very good for B-ALL because most of the mutations, not all, but most, are reciprocal translocations, and those are being missed by most of the sequencing platforms. It's very good, as Dr. Kuhl's mentioned and presented, in T-ALL. So in T-ALL, a high percentage of the time, most of our next generation sequencing platforms are rich in terms of yielding a lot of interesting information with respect to notch mutations and which type of notch mutations, or the IL-7 JAK-STAT pathway mutations, or others. But in B-ALL, it's rarer. With the exception of loss of Ikaros, which was mentioned by Dr. Brueggemann and others. But most of it are reciprocal translocations. And so that pH-like signature, it's not trivial. And many standard, at least in the United States, most labs are incapable of actually addressing that. There are new technologies at place, nanostring technologies, RNA-seq, things like that, that are being incorporated into some of the academic centers in order to pick up a higher percentage of those patients with pH-like signatures, but it's a different disease.
And still no prospective good trial. And I think the diagnostic difficulties are the reason for that. I thought that NGS may help if we have in adults, out of the MRD negative patients, clearly negative, still 20 to 30% relapse, mostly standard. So we have to segregate subgroups. PH-like is one, but also we may discover sub-entities by NGS, where we can say here's is MRD negative by our conventional PCR, but he has a subclone which is prone for a relapse. There are some observations in pediatric ALL with rare genetic aberrations. They are all MRD positive, and they relapse after 3 to 4 years. And we now know exactly which clone it is. This might help to reduce the number of so-called MRD negative patients.
Absolutely. Dr. Hoelzer, any final thoughts? I mean, I think I wanted to also capture your moments on becoming the president of the Society of Hematologic Oncology, and how do you see conferences such as these helping and moving the questions that we asked forward, and also getting the next generation of researchers inspired to do this kind of work?
I think the SOHO is a unique concept, and it's very simple. All the educations and the malignant hematological disease are in one room and not dispersed in parallel sessions. So if you would like to have education, you can go for 3.5 days and you learn a lot. That's the first thing, you know. It's not distributed to run to education sessions. Somewhere you miss it and so on. And I think that's a great advantage. Second, the number of travel grants is increasing, and it's on a purpose to attract young clinicians and researchers from different countries. This is one of the major purposes. We discussed it today in the steering committee, and I think we will have clusters in the different countries to attract young people just for the reason of education, but also to improve and extend good posters in this meeting. So it has a future. We discussed already that we should not grow as large as other meetings with a lot of parallel sessions and a very huge number of attendees.
Excellent. Any final thoughts, Dr. DeAngelo?
Well, I mean, congratulations, Dr. Hoelzer, but I mean, this has always been a very enjoyable meeting for the reasons that he outlined. Back to the topic of ALL, it's a very exciting time as I haven't been in the field quite as long as Dr. Hoelzer, but it's you know, over the last 3 or 4 years, it's you know, it was the wicked stepchild of AML, where nothing new was happening, and now everything's exploding, and it's going to be a very interesting time, and it's a very good time for the patients who with the disease. So hopefully more of them will be cured.
To finish with a teleological remark, you know, it's an absolutely rare disease. You can cure it in children, but just in this rare disease, it's the ideal disease to follow MRD and to explore new techniques like CAR-T. You would never expect it, and we are lucky to be in the field and to see this progress.
Absolutely, Dr. Hoelzer. I'm so inspired by the work that you've done, and thank you very much. Thank you for the time, and we'll stop here.